Paul, why don't you kick us off? Why do people get muscle cramps and what's the solution?
First of all, it's multifactorial. That's a doctor's way of saying there's lots of stuff and we don't really know. But there's a few things that we do know. There's associations with low sodium, which is found in table salt, and low levels of magnesium. And one of the things we find that supplementing with adequate levels of both of these usually deals with probably about 90-95% of the cramps my patients get. So with magnesium, it comes in different forms. So magnesium combines with something else, and that's the form you buy. It could be combined with magnesium oxide or citrate or aspartate. So you have to be very aware that some of these magnesium formulations can cause diarrhea, and because of that, they're not well absorbed. So the type of magnesiums that I like would be a magnesium chloride or a magnesium aspartate, and they're two that we've got experience with in the clinic that are beneficial. And then, as I said before, with sodium, we like people to have a minimum sodium intake, and I would probably recommend at a minimum you need to be having 3 grams of sodium a day, and preferably up to 6.
Paul, can I just ask the dose? Because I know some people who are on 60 milligrams of magnesium, and I know other people who take 1,000 milligrams, and I know one guy who takes 5 grams of it to control his atrial fibrillation. So what's a middling amount of magnesium?
So when you buy magnesium and you look at the size of the tablets, they don't actually always account for the amount of magnesium in the tablet. They'll give you the total. So you've got a magnesium here, and then you've got something like an aspartate or a chloride or some kind of amino acid that it's chelated with. And depending on the size of the molecule that it's chelated with, if you've got a big molecule chelated with a small magnesium, then even you might be having 5 grams but be getting a very small amount of magnesium. So I don't like to say brands, but the easiest thing that we do is to make it simple is say there's a brand that we used to use in the hospitals. When I was a resident in the hospitals running around, we often supplement it with magnesium aspartate, MagMin, and 2 or 3 of those a night should be sufficient.
So, I mean, one of the other things that I found personally, if I've spent a long day operating and I'm dehydrated and I don't drink enough that day, and it's got very little to do with salt or magnesium, but just pure dehydration, for me, creates muscle cramps unrelated to either the salt or the magnesium. So I think it is multifactorial. Gary, you're about to make a comment?
With the salt, throw it on your food. So if every meal, throw a little bit on. We use sea salt, sprinkle it on. Do not be worried about the upper limit, which is really what Paul was talking about. Why do we have a magnesium deficiency? I mean, it's really interesting is that our agricultural practice is to put fertiliser on the soil. And when you put all that potassium into the soil, it actually binds the magnesium. So the magnesium is actually not getting into our food. So it's not getting into our plants, it's not getting into our animals. So it's just a side issue with the whole magnesium question. And so supplementing it is one way. The other thing is to be a little bit more mindful of where your food comes from.
Just a quick word on salt. The medical profession, for some reason, is obsessed with salt. They think we should all be reducing the amount of salt we have. As most of you know, if you're on a low-carb, high-fat diet, you have very little salt because most of the salt that our society consumes is in processed food and added. So if you're eating a real food diet, you're actually a pretty low salt intake, and we actually need to supplement with salt. So as Gary said, sprinkle a lot on your foods. I have 2 quirky little things I do with salt. I have a cup of bone broth every morning, and I put a fair bit of salt in that. And I have salt in my green tea, which you might think is a bit weird, but that's okay. And the final word is, I think the medical profession have chosen the wrong white crystal to get worried about.
Just on that, I'd just like to inquire of the other panellists what supplements they take. I take magnesium each day. I've recently started taking a multivitamin just to see if it makes any difference. Steve Finney, who I respect his opinion, he says a multivitamin, it's just like a bit of insurance. It might not make any difference, but it just might. But I'd just be curious of the other panel members and Doron, what do they do?
So personally, I like fish oil. I've actually started taking cod liver oil. The reason is that it's actually got some other nutrition as well as the omega-3s in it. It's also got vitamin A, and which is something, again, that we don't get very much of in the diet. I also take magnesium. I take magnesium aspartate. I'll only talk specifically about supplements that are pertaining to metabolic health here. With my patients, I often put them on chromium percolinate, which has been shown to be an insulin sensitizer quite reliably in the research. There's also a supplement called lecithin, which contains choline, which has got very good evidence as treating fatty liver. That's an individual one. And I've got a whole list. If somebody's got a history of squamous cell carcinoma, which is a pre-cancerous skin cancer lesion, there's evidence that taking vitamin B3 in the form of nicotinamide, 500 milligrams a day, will speed the resolution of that. So, I mean, there's a whole... I've got a list of about 20 different supplements which have varying degrees of evidence for different conditions, and I'll really personalise it. So if somebody comes in on a statin, for instance, I'll give them coenzyme Q10. And out of interest, when the statin medications were first being tested, they actually predicted from the biochemistry that it was probably going to affect the muscles. So the first studies on statins actually combined it with coenzyme Q10, just out of interest. And now that knowledge seems to have been lost.
0. I take no supplements. I believe that we shouldn't need to take supplements. You know, we haven't taken supplements for the last 10,000 years. Why should we start taking supplements now? It just shows that you're deficient in your diet. And I think if you have a good, real food diet, you shouldn't need supplements.
I think, to respect Paul, if you're talking about patients or people that have medical conditions and there are specific issues and they've gotten into those deficiency states, then there may be a role for it. The supplement I take is, I live in a place called Tasmania. And so I have this thing called fresh air. Some of you watch Four Corners saw the view out my window. And we have fresh, local, seasonal food, jerf. You know, and if you're well and you're not sick, then I think there's no role for supplements.
And then the other thing to add is if you're eating fat is actually a higher vitamin source than most other foods. So that's where most of the vitamins are. So if you're eating low-fat foods, you're not getting many of the vitamins that you're going to get from the fat. So you eat the fat, you get the vitamins. All right, so Gary, there's a couple of double-barrel questions. I'll just start with you because you mentioned the cholesterol. If cholesterol doesn't cause heart attacks, what's the main factor that does?
That's covered in my nutritional model of inflammation and modern disease.
I'm setting you up here to answer.
Thank you. I sometimes walk through an open door.
Can you keep it to 3 minutes, sir?
Yes.
Hurry up.
Fructose, the combination of fructose, refined carbohydrate and polyunsaturated oils creates inflammation in every blood vessel wall and in every cell membrane in the body. And so our modern diet is highly inflammatory, and it's not just sugar, it's not just carbs, it's not just insulin. I think the polyunsaturated oils have a major incriminating role. So you could have a very high sugar diet, very high carbohydrate diet from an inflammatory point of view, and have fill it up just with all those byproducts and the LDLs with saturated fats, and it wouldn't be a problem. You could have a very low sugar, low carbohydrate diet, but if your diet is full of very high in polyunsaturated oils, the omega-6s, then that's going to be inflammatory. It's the combination of the three. So for personally, I have a low inflammatory diet. It's very low in sugar, very low in carbohydrate, very low in polyunsaturated seed oils, vegetable oils, whichever way you want to call it. So inflammation sits underneath every single modern disease. Our diet is the major producer of that, and therefore if you reduce those three things, they're the major players. I think I don't know everything on this, but that's the model, that's the concept, and if we reduce those, then the other things sort themselves out along the way. So the role of that is if you have inflammation in a blood vessel wall, over a long period of time, it's more likely to be injured. That's the cause of cardiac disease. Well, it's not just heart attacks, but it's cardiovascular disease. Was that long enough?
Perfect. Paul?
So just to add to that about why cholesterol becomes harmful, it actually comes back down to sugar again if we're looking specifically at cholesterol. Most of you have probably heard about the small, dense cholesterol particles. Well, they become small, dense because they become glycated. We've heard about the advanced glycated end products, and you've got proteins on these lipoprotein particles, and the B100 protein that identifies the LDL particles can become damaged by sugar. And when that becomes damaged, there's actually been studies that have been done in Japan that actually show the size of those particles then become smaller, and that then becomes what's defined as small dense. And because this receptor has been damaged, the cholesterol is not able to be taken out of circulation by the liver, so then it ends up being taken out of circulation by these macrophages, which then bury it inside the lining of the blood vessels. So at the end of the day, when you're worrying about cholesterol, so it's true, and Marianne intimated before, that high saturated fat diets make your cholesterol go up, but it's sugar that makes your cholesterol go bad.
And Paul actually did a beautiful lecture on this on that in November of last year, which is actually up on YouTube, both on the Low Carb Down Under website and our website. So I'd recommend you, if you're interested in that, you go and have a look at that. Rod, I'm going to bring the panel back to you over here. This is a question we get asked all the time. There's certain lifestyle designers or exercise people that suggest a weekly carb load. With the strength benefits, etc. And to what's the other thing they say, to prevent metabolic downregulation. I might just work a way out across the panel. What do you think of a weekly carb load or a weekly cheat, if you want to call it something else?
Carb cycling, sometimes called. And look, I've got to say I'm not a fan. I can't see a benefit to it. It would boot you out of ketosis, and we've been hearing the beneficial effects of those ketone molecules on our metabolism. So to me, it's like a backward step. Maybe the only people who might do it might be people in high-intensity sport who might train low during the week and on match day have a modest amount of carbs on the day. Peter Brukner would probably address that group better than me, but that would be my take on carb cycling. I'm not for it.
I'll leave the sports side of that to Peter. In nature, which is what I always come back to, what would actually be happening in nature? And in nature, we never actually tested ketone levels. And every time I test, I'm in ketosis. But I think there's been some suggestion that maybe there's arguments, particularly in cancer, to actually cycle in and out of ketosis might actually be more beneficial, might be more creating a mixed environment for a cancer, might have some benefit. So in nature, if you're running around there, you might have just happened to come across a crop of fruit and get hold of it, and you're going to bounce in and out of it. So I'm not too fussed about the level of ketosis, and I realise that's contentious. I think it's a good spot to be most of the time. I'm not too fussed if you cycle in and out of it, because I think that probably happened in nature. But do I do it? No, because I can't find any carbs in our house. You can find it in the theatre suite. But so I personally don't cycle in and out of it, but from a theoretical aspect, I don't think there's a huge fuss as long as you've got strong will. But a lot of people don't have, and if you actually get back on that bandwagon, it's easy to get back into trouble again.
From a sporting point of view, well, I did have one particular cricketer who'll remain nameless, but he's currently suspended, who went on this low-carb, high-fat diet and really benefited from it. But he did love his carbs, so we came to an agreement about Carb Sunday. and he would, so get into the Carb Sunday. And then it sort of got extended to it was Sunday somewhere in the world. And so it became a very long, and then when he sort of started trying to tell me that on Tuesdays, I thought, no, hang on a minute, there's nowhere in the world it is still Sunday. So Carb Sunday was the go. But I don't think it's necessary, and I tend to agree with Rod. Just very quickly from a performance point of view, obviously, for the last 30 or 40 years, it's been the carb generation. There's been carbs, pasta parties the night before the marathon, and Gatorade and Powerade and all that sort of stuff. More and more, particularly endurance athletes, are switching over to a low-carb, high-fat diet so that they're fueled primarily by fat rather than by carbohydrate. And that seems to work very well at low to moderate intensities of exercise. So these, crazy people who run 100 miles and all that sort of stuff, they're on low-carb, high-fat diet. The challenge is the sort of the middle group that still need to do high intensity. So it might be a cyclist who needs to sort of climb a hill or sprint, or a footballer or a basketballer who needs sort of bursts of intense energy. And what a lot of football teams and others are doing at the moment is this concept of train low, compete high. So that their basic diet is low carb, so that they get their fat oxidation going and their fat metabolism going. And then on days of intense training, so that they basically titrate their carbohydrate intake depending on how much training they're doing. So on their really hard training days or on match days, they'll have a moderate amount, not a huge amount of carbs, not like the sort of pasta parties of the past, but a moderate amount of carbs maybe the night before or the morning of a game or a hard training session. So, for instance, say a Chris Froome, the Tour de France cyclist, he's, been photographed with a sort of a very low-carb, high-fat breakfast that photo's done the rounds and so on. But he's one of these people who cycles in and out of low-carb depending on his training load for that day. So if he's just doing a steady-state training day, he'll go low carb, high fat. But if he's got a day where he's got some intense hill sessions and so on, he finds he just needs those extra carbs. So there's a lot of individual variation. Some people are fine on low carb, high fat, no matter what they do. Others need more carbs than others. So I encourage my athletes to do a little bit of trial and error, find out exactly how much they need. But their general sort of day-to-day lifestyle is low carb.
For me personally, I don't see any benefit to cycling with carbs. There was just a paper published recently looking at high-intensity efforts, and the difference between that study and some of the previous studies was that it had a 4-week adaptation period. And when you have the 4 weeks adaptation period, they actually found there was no decrement at all in high-intensity exercise. There's been studies that have looked at glycogen levels in muscle, which we assumed would be lower on a low carbohydrate diet, but when we measured it, they actually weren't on properly adapted athletes. And even if athletes are depleting their glycogen, I think you can actually intelligently supplement with carbohydrates. I recommend something called UCAN, which is a special starch matrix, which has a much lower insulin spike than other carbohydrates, and so you can actually start to replenish your carbohydrate stores while still being in ketosis. And the beauty about doing both is that then your body's got access to 2 types of energy. It can use ketones and it can use the glucose or glycogen or carbohydrates as energy.
So I have to say, when I get asked this question, I have a slightly different answer to that, and I go back to the person and say, well, what are your goals and how metabolically well or unwell are you? Because, for example, my mother, who is type 2 diabetic, if she did that, it's going to kick her out of ketosis for a week or more, and her sugars are going to go high. She's going to be very unwell and very unhealthy. So a cheat meal for her isn't possible. She's metabolically unwell. Somebody else, they might be trying to lose weight. Well, if you're trying to lose weight and you have a cheat meal, it's going to sabotage your weight loss. Somebody else, they may just, be somebody's birthday party, they want to engage socially and they don't have any of the sugar drives afterwards. So for them, it's not a problem having that. But to schedule it in your week once a week, I think is a mistake, number one. And I personally don't mind people doing it once a month, once every 2 or 3 months. But I personally think you've got to look much more at what your goals are and whether you're metabolically well or not, whether you can afford to do that. Any disagreement with.
Yeah, I just wanted to add a point just drawn from evolutionary biology. So Gary talked about if you stumbled on some fruit as a cave person, as a paleo person, yes, you would consume it if it was around for quite a while, which it might be at the end of summer and into autumn. You would then get a lot of it. You would become insulin resistant. You would pack on fat, and that would help you survive a long winter. And the problem for us in our day and age is we do it 365 days a year. So for a cave person, yes, there was an evolutionary advantage to doing it. For us, we don't want to be doing it all the time.
Paul, you've dealt with this quite a bit. I might direct this question at you because there's a lot of them. Can you tell us a little bit about if somebody's had their gallbladder removed or if they've got gallstones and they want to eat this type of diet? So the medical name for that is a cholecystectomy.
So we tend to blame high-fat diets on gallstones because what happens is it's a high-fat meal that leads to this severe pain up under the right ribs and you end up in hospital. And the reason we blame high-fat diets is because the attack was triggered by high-fat diets and our doctor tells us it was because of the high-fat diets. But that's wrong. So when we think about it, the gallbladder is filled with fluid like detergent that helps the body digest fat. So it's a reservoir, and every time you eat a high-fat meal, it squeezes empty and squeezes this detergent-like bile into the intestines where it can mix with fat and then it can subsequently be absorbed. So if you don't eat fat because you follow the low-fat dogma, your gallbladder doesn't empty. So you've got this fluid sitting there, and then it turns to sludge, it thickens, and then an extension of that process is it can eventually form stones. So then what happens is 99% of the time you're very, very good on the low-fat diet, then you go and have a meal of fish and chips. Your gallbladder tries to empty, and you've got this stone, and it's got a little tiny exit, and that stone gets wedged up in the exit, blocks it, you get a severe attack of pain. Now, what caused the stones to form? The lack of regular emptying. It wasn't caused by the high-fat diet. The high-fat diet just brought the attack on. And what we've actually shown in my patients is that if we have a look at their gallbladder before and after they start a ketogenic diet, we can actually see those stones dissolve and disappear over time. And in actual fact, we used to give one of these detergents in a tablet called ursodeoxycholic acid to dissolve it. And the medical literature is got heaps of cases where we know we can dissolve gallstones, and that's fallen out of favour. The reason is because as soon as somebody dissolves the gallstones, they're fantastic, but they're still put on a low-fat diet, so they just reform. And standard medical theory is, well, if it's just going to come back, why don't we just cut it out because, you know, I've got a second mortgage and I want to buy another car. So that's not for everybody, but that's a prevailing medical paradigm regarding gallstones. And we know that people who have gallstones, only about 15% of them will have an attack over a 10 or 15-year period. So most of my patients, even though they do have gallstones, there is a small risk of having an attack, and a couple of my patients have had an attack, 2 or 3, out of, hundreds. And most of those, it gets better. They just deal with it. They elect not to have it out surgically, and when you re-ultrasound the gallbladder, the stones are gone.
I'm not going to try and defend my surgical colleagues. They're big boys and women. Patients after they've had a cholecystectomy can still run LCHF, and because the biliary tree, which is it's not just the gallbladder that's producing the detergent. It's a great analogy. That's all that bile fluids come from the biliary tree, right from the liver, and then it gets stored there for those meals. So the biliary tree, which is producing it, can sort of upregulate over time. So it's a matter of just over a period of time, if you've had a gallbladder out, that it may be that you need to increase your fat intake a little bit more slowly than the average person, but it will recover. Common question is fine.
Totally agree.
And in fact, there's a few questions here about people having a diarrhea type response when they have a lot of fat. Paul, do you want to address that one as well?
No, give that to Peter. He loves full of...
You're the one who's full of shit. Come on.
What,
I didn't say it.
what was that chemical milieu of sugars called? So first of all, if you have what we call steatorrhea, which is diarrhea from fat, it's a very particular kind. You actually look in the bowl, you'll have a slick on top of the water because it floats on top of the water. So when people think that they have malabsorption, when I actually ask them, describe what you see, it's usually not fat, number one. It's often, so something else like the polyols, remember the low-carb bars with the artificial sweeteners? It's usually something like that that's causing it. True fat malabsorption following having the gallbladder out, to be honest, I'm having trouble recalling any cases at all that I've seen.
All right. Rod, you've been doing this for a while. What do you do in a social situation where someone comes and, basically tries to force a piece of carbohydrate down your throat? People can be very insistent, and particularly if they know that you don't want to eat it, they really try even harder to get you to eat it. So what's your method of dealing with that?
Yeah, I think I've toughened up and I just don't want to go back. And the more years I've been doing it, the less I want to have a cheat day or anything like that. Having said that, occasionally, special family occasion, there's hazelnut meringue cake, which it's a specialty in our family. It's gone through the generations and it's continued to be made. So I will have a narrow sliver of that when it is offered.
You can cheat on this by smelling the cake. Remember, most of taste comes from your olfactory nerve, from the smell. You can do that. When you've got a cold, food doesn't taste any good. So you can actually do that test where you actually put a lolly, block your nose, put a lolly in your mouth, wait for the sweet sensation, unblock your nose, and you get this second wave. So realistically, if you want to have that cake, so our daughter's wedding, we had a wedding cake. It was about this big, right? And I just got everyone to sniff it. But literally, you can actually smell it. Just do it. Get that sweet, smell it. It will go up. It'll hit your nucleus accumbens. You will get your chemical hit. You will go, oh, I've gotten that. Then you'll get a second joy because you haven't gotten the calories in, and you get a third joy in that you've actually cheated yourself. And just one anecdote, because of the temptation, I came into the theatre tea room and there was all the staff there, and there was that whole tray of coloured carbohydrate and junk food there. And I walk into, I don't have to only walk in now, and everyone turns around and what's he going to say? And there was a rep there who'd brought 2 cakes for us to eat, and one was pavlova and the other one with fruit on top, and the other one was something other. And I said, oh, look, thank you very much. You brought all this cake in for the staff. I'd like to eat the best bit of it. And they thought I was going to go for the fruit. So what I did, I went up and I got the cardboard box and ate that.
Peter, did you have a comment with that one? No? Okay. Well,
Just like to say, Gary,
you
probably didn't need the fibre.
Well, but Peter, this is relevant to the sugar by half as well. I mean, what do you say when people give you the standard thing? Well, sugar's not that bad.
Well, look, I think we all have an amount of carbohydrates that we can tolerate, and that varies from person to person. I mean, I think if you're significantly insulin resistant, you're type 2 diabetic, you're metabolic syndrome, you've got one of those chronic diseases that I mentioned, you've got to be really strict. And you've got to restrict yourself to 20 or 30 grams of carbohydrates a day. But on the other hand, if you're relatively insulin sensitive, as many young people are, I don't see a problem with them having a dessert every now and then. But it should be a treat. In the old days, desserts were a treat. Now, breakfast cereal is a dessert. So we're having dessert all day. So I don't have a problem with that for those who can tolerate it. But there's a huge amount. It's that old story. There's no one diet for every person. There's a huge amount of variation on the amount of carbohydrate we can each tolerate. And for a lot of people, I have the odd, I have a bit of a weakness for the odd creme brulee or a bit of a chocolate souffle or something like that. But, I might have that once a month rather than, every night. And, so I think, we can't be too, autocratic about this sort of a thing. For a lot of people, why not have a treat? It's fun.
Paul, there's a number of questions here about kidney disease. Protein's bad for kidneys, salt's bad for kidneys. Can I eat low-carb, high-fat if I've got kidney disease? Do you want to give us a little bit of a do on kidney disease and low-carb?
When kidney disease gets bad enough, we end up on dialysis. Do you know what the most common cause of people going on dialysis in Australia is? Diabetes. There is no evidence, there is zero evidence at all that protein damages the kidneys. That was, again, a bit of extrapolation from a bit of bad science. If anything, if you're losing protein through your kidneys, you might actually want to have, theoretically, and I'm not suggesting you do, but if you're losing protein, maybe you want to have a little bit more. With regards to salt being bad for your kidneys, the reason we say salt is bad is because it can lead to higher blood pressure. And the kidneys are actually what determines whether our blood pressure goes up or down. But our kidneys' handling of salt is determined by insulin. So if you have low levels of insulin, there's 4 different receptors in the kidneys, including one that all the doctors here will know is called the ENaC channel that's activated by aldosterone. That's also activated by insulin. So if you lower your insulin levels, it doesn't matter how much salt you have, the kidneys will let it just pass out. If you want to, what I consider the smartest doctors, they're renal doctors because the kidneys are horribly complex. And when I read their journals, they describe what is termed essential hypertension, which when I was in medical school, we just said, well, that's just blood pressure. We call it essential because we don't know what causes it. The kidney doctors describe blood pressure as essential hypertension as an insulin-dependent state. They understand very clearly that if your insulin level is low, you don't have high blood pressure. So I would say that if you're worried about kidney disease, I mean, as long as you don't have one of these weird and wonderful conditions, the most common cause is diabetes. Keep your blood sugar down, and if you're worried about salt, keep your insulin level down, and if you're worried about protein, don't be.
I've got a couple of patients with end-stage diabetes, just pre-dialysis, and their kidney function's improved over 2 to 3 years. I'm not saying it's going to reverse on the whole, but I have 3 that I can say that. The other thing is the Northern Territory's answer to the Indigenous diabetes epidemic and the increased problems of dialysis, people requiring dialysis, is not prevention, it's let's buy more dialysis machines. It's completely unsustainable.
And that concept can be a little bit difficult to picture in your head. So both in Paul's talk from November and my talk, which are both up there, you can see diagrams of what Paul's talking about with those sodium channels and insulin and how the sodium gets excreted. So not a bad idea to do some revision if you don't remember those talks. Go back and have a look and you'll see the pictures which will make what Paul explained now a little bit easier to understand. All right, so Peter, you're the sports exercise person. There's a lot of talk about exogenous ketones. So I'm just going to take the ketones and I'm not going to change my diet. I'm going to get all the advantages of ketosis and it's going to make me perform better. Can you give us a little bit of your thoughts on that?
Yeah, look, it's obviously a very controversial area. And there are a lot of big commercial interests who want to make this work and want to convince us that exogenous ketones, in other words, ketone supplements, are the best thing since sliced bread. No, sliced bread is no good. Since anyway, so it's a very hard to sort of separate the propaganda from the science. And unfortunately, the science hasn't really been done on these ketone supplements. So really, I think the jury is still out, and I'm certainly not convinced at this stage that they're a great thing for performance. I think natural ketosis is much better. I mean, if you're taking ketone supplements and you've still got a high, carbohydrate intake and high insulin, then it sort of seems to defeat the purpose to me. So I think you are better off with natural ketosis than ketone supplements. But I accept that the jury is still out. We need to do the proper research and find out in which situations, in what levels of carbohydrate intake that you have with the supplements, et cetera, et cetera. We're a long way from knowing the answers to that question. I know it's a bit of a cop-out, but at the moment I'm not recommending it to my athletes.
Paul, just on that note, any idea or seen anything on the bioavailability of ketones after they've transited the stomach with all that acid?
I don't actually, but I do know that when we have a look at other supplements which would increase your ketones, such as your medium chain triglycerides, especially the what we call C8 caprylic acid, that you do get a significant boost in your ketones. But my concern with the ketones is that people use them for weight loss. And the reason that it's hard to get high levels of ketones and that they'll never go, super, super high is that because the ketones themselves exert negative feedback on fat metabolism. So if you're burning fat and creating your own ketones and that's exerting negative feedback on the process, well, that's very natural because we don't want the ketones to go necessarily too high. But if you're having what we call exogenous ketones, you're eating them or drinking them, then that has a capacity to inhibit your fat metabolism. You're still putting energy into your body, and your body's got a choice. It's either going to burn what you're putting in your mouth, and if you don't put something in your mouth, then it's got the capacity to burn your fat stores instead. So it can actually be quite counterproductive in terms of weight loss, and that's something which a lot of people overlook. Now, what Peter was talking about with regards to athletic performance, that's a totally different kettle of fish, and I'm actually a firm believer that they can be what we call ergogenic. They can make athletes perform better, but for somebody trying to lose weight, I don't recommend it.
So there's, I don't want to rubbish anybody. So if you did write this comment, I'm actually not trying to make fun of you. But is a low carb diet appropriate for my 16-year-old daughter who is a high-level gymnast? She is healthy and not at risk. So does anybody believe that eating lots of carbohydrates your whole life does not put you at risk? See, to me, eating carbs puts you at risk regardless of your age, activity level, etc. Rod, any different?
I have real concerns about the fact that our athletes, our athletic population, have been so obsessed with carbs for the last 30 or 40 years. We have a whole generation of athletes who have had massively high levels of carbohydrate intake for 10, 20, 30 years, often in the form of very simple carbohydrates in the sports drinks, the Powerade and Gatorade and so on. And they're having huge amounts over a long period of time. And I have grave concerns of the long-term effects of that. They will almost inevitably become insulin resistant and develop all the complications associated with that. We see quite a high incidence. This is just anecdotal, but there's a lot of concern that there seem to be a lot of retired endurance athletes who are developing heart problems at a fairly young age. And it's always sort of been explained by saying, well, it's the strain they put on their heart while they were competing. Well, I suspect it may have a lot to do with not what the strain in their heart, but what they're putting in their gut. And I think I have real concerns about that. And so that's why I really like this idea of the train low idea of having a low level of carbohydrates in the training phase, and then if you need to top up, just topping up occasionally. Much better than this constant high level of carbohydrates with disastrous consequences.
So that's interesting, and there's certainly a lot of case studies of the 300 or 400 pound linebacker in American football are having heart attacks at young age. But just to answer the question more specifically on gymnastics and low carbohydrate diets, one of the very first studies that was actually done in elite level athletes, it was done by an Italian team, was looking at elite level gymnasts. And it didn't necessarily assess their metabolic health, but one can only assume that it improved. They found that they lost body weight And importantly, they did not lose power or strength during that. So they maintained the same strength, they lost body weight, so their power to weight ratio actually increased. So from an athletic point of view, this Italian study would seem to indicate that even for these power athletes, which is one group of athletes which we tend not to recommend low carb for, well, this study actually seemed to demonstrate some benefit.
Again, Rod, I'll just come back across this, and if we can work our way across the panel, please. If I cook a high-fat food and another member of my family adds carbohydrates or some other junk food to it, is that worse for them than if they were just to eat the junk food on its own?
Can someone start on that? I'm not quite getting that one.
Yes.
Okay, Paul. Okay. So essentially, what you do is you're at home. You bring out your beautiful high-fat food for dinner. You put it on the table, and instead of them just eating that, they get out a piece of toast and they put the piece of beautiful fatty meat on the toast and eat the two together. Is that worse than them just eating the toast without the super fatty meat on it? Should they be having lean meat if they're going to eat the toast?
Yeah, this is a very interesting one. And basically, we're almost talking for that person, they're having high fat and high carb all at once. And I think the consensus is that doesn't work. So this high fat that we're talking about is in the context of low carb. If we're having lots of carbs as well, I think studies over time have shown that's actually a bad mix and gives us bad outcomes. And that's possibly one of the reasons why fat got a bad name over time, because it was always more fat in the presence of lots of carbs, and lots of carbs turning on the insulin. So yeah, I wouldn't be advising a high carb and high fat.
That's one of the theories behind the rebound after diets, that the weight bounces back on and bounces back past the point when they started. We're as a group here, I think we're all moving towards that simple concept of high carb or low carb, healthy fat rather than high fat. Once you mix it up, then is that the day you're falling off the bandwagon? Very simply, don't invite that person back.
I think the question was actually about a member of their family.
Disinherit them. That's what we've done with our son. He's coming around because I've disinherited him. Okay.
What that question essentially described was a donut.
Yeah, no, I agree. That's the ultimate high-fat, high-carb food, and it's certainly not very good for you. A fairly straightforward question. How do you calculate lean body weight to be able to work out the amount of protein you should be eating? Anybody?
Why do you want to do that? I mean, I've been accused at these panels of being the laid-back low carber, and I openly admit it. I mean, I've got no idea how many calories I have in. I have no idea how many grams of anything I eat. I've never photographed a meal. If it appeared on Facebook, someone's put it there. I eat very low carbohydrate. I just don't know how much I have. And I have vegetables, so I'm getting some in there. I have meat, so there's some glycogen in there. It's coming in. How much fat I eat to satiety, and how much protein I eat is my body now tells me how much protein I need. It's really interesting. Once you get rid of the sugar out of the diet, which is a major distractor on how your feedback mechanisms, your body will tell you, I need a bit more protein. So obviously, if you're very young and growing, or you're very old and debilitated and need a bit more protein, those two states, so if you're exercising a lot, you need a bit more protein, your body will tell you to try and actually get out and measure how much protein you're needing, lean body weight, nothing personal, but then crikey, you're making it too hard on yourself.
Well, although that's if you're metabolically well, I agree that that's the case. But because protein does cause an insulin spike, if you're metabolically unwell, the amount of protein that you're eating may actually be important to you. And I don't think you can intuitively know internally what that's doing for you. So if you're someone that's really metabolically unwell with strong insulin resistance, one of the ways that we do it, and Paul can talk more about this, is actually getting people to test their ketones and see what happens with the amount of protein that you have. So you keep ramping up your protein until it takes you out of ketosis, and then you understand at that particular moment in time, that's how much protein you can handle and still stay within your fat burning zone. But if you're well, then absolutely, just follow your body. But if you're really metabolically unwell,
I'm just concerned that
we're
making it too hard, and I think it's a journey, and I think you actually work it out slowly over. I don't have it worked out, but I'm still fiddling around, and I've been doing it for 8 years.
I think we're probably comparing two different things here. So I agree with Gary's premise, and especially from an athletic point of view, that the whole science about how much protein you need isn't there yet. If you go into the AIS website and have a look at their nutrition section there, they'll tell you need between, if you're a resistance athlete, maybe between 1.2 and 1.4 grams per kilogram per day. If you're a cardiac athlete, up to this, and an extreme endurance athlete might need up to 2.0 grams per kilogram of lean mass a day. And that's really bad science. There's actually not clear data on these numbers. So it sounds like the person who's asked this question maybe has had a specific recommendation to have a particular protein intake based on that. Now, there is some very good evidence that if you have a leucine-rich protein that's got a broad spectrum of amino acids, and if you say whey protein and have a dose of that 4 times a day, that's about optimal to stimulate muscle anabolism. But the simple fact is, on an appropriately formulated low carbohydrate, we get plenty of protein in here, and I'm approaching something of a carnivore. And I know that I get a lot of protein in my diet, and as Doron alluded to, for some people that can be a problem. So I think as the rough rule of thumb, which I give people, and I think Gary will probably agree with his keep it simple approach, is I say don't eat naked meat. So what do I mean by that? Don't cut the fat off your steak. Buy the cheap mince, the stuff with the fat in it. If you're eating chicken, don't eat the chicken breast without the skin, eat the chicken wings with the skin. So when we have a look at nature and how it packages protein, it's usually packaged with fat. So if you're going to consume protein, consume it with the fat. On a low-carb diet, almost certainly you're probably going to get enough protein anyway without measuring it. Just make sure it's well balanced with fat.
One of the components of that question that comes up for me is, should we measure or do we not need to measure? There's a wonderful woman in Melbourne called Dale, who's now about 70, who has dropped 12 jeans sizes. She has been morbidly obese for much of her life, and she has finally nailed it over the last couple of years. And she does it by weighing and measuring very carefully and tracks every day, and that has got her to a wonderful place after a lot of dark years, and that works for her.
Gary, is fructose ever okay? Can I eat one apple?
If you're a sperm. For sperm production, they're actually, sperm motility, they actually require fructose, and that's probably the only biochemical pathway that fructose is required for. I've actually asked Luke Taffy that, who was probably the person who described fructose metabolism pretty well in 2010. I flew all the way to Sydney to actually ask him that, not just that question. But one question I did ask him is there a human physiological biochemical pathway that requires ingested sugar? The answer was no. And the same thing goes with fructose. You don't need it, apart from if you're a sperm, and the body will produce a little bit of that anyway. Again, if you want to eat fruit, I get asked this all the time. I say, well, if you want to eat fruit, yes, have it as fresh, local and seasonal. Understand that it's in nature, it's designed to turn into fat for winter hibernation. If you want to eat your apple, eat it off your tree that's grown in your own backyard that you've fought with the possums to Don't buy it with the supermarket, where it's actually last year's apples. Everything comes into Tasmania is fumigated, including tourists. Yeah, I pulled the drawbridge up. It's got too much good stuff happening there. So, what was the question? Can I have an apple? You can have an apple, but there is no human biochemical requirement for it in the body. Carbohydrate is energy dense, nutrient poor in virtually every form that it comes in, whereas the healthy fats, the proteins, we have essential requirements for essential proteins and essential fats. And the fat-soluble ones are the ones which we don't have, and if you don't have them in your diet, you don't absorb your vitamins.
If I could just make a comment on nutrient density. So a lot of people are concerned that if they're not having vegetables, they're missing out on the most nutritious foods that they can possibly have. So when you see those tables, you have to understand that it's a fraction. You've got a numerator, number on top, and a denominator. And what they do, they calculate the absolute amount of nutrients in the food, and then because fat is so bad, they divide it by the amount of fat. So if you divide a number by a bigger number, you end up with a littler number. So what this does is it biases against animal products. So that's why you can have something like a carrot possibly being considered to be more nutritious than a piece of cheese or a piece of meat, which is absolutely ludicrous. So the other feature about nutrition is that we divide it by fat because we think fat is bad, but fat is also an essential nutrient. So, as Gary said several times, you can survive without ingesting carbohydrates. Your body will make what little glucose it needs, but you cannot survive without fat. Fat is actually a nutrient in itself in the same way that protein is. So the way these equations work to give us these rankings of nutrient density of foods is absolutely ludicrous. So don't be deceived in thinking that vegetable sources of food are more nutritious than animal sources of food.
And just to adding to the fruit comment, something that I struggled with when I was learning the science, I knew that fructose really didn't create an insulin spike. So I couldn't understand why eating fruit would kick me out of ketosis if ketosis was my goal. And it actually took me a long time to understand that fruit doesn't just have fructose in it, it's also got glucose in it. And so when you eat it, you're not just getting fructose, you're getting fructose and glucose, and that's where often you can get kicked out of ketosis if ketosis is your goal. It's not just fructose in the fruit. All right. Anybody can comment on this. What are your thoughts on metformin? Some people use it for weight loss. There's a certain appetite suppressant for it. It pushes glucose into muscle tissue. Can we recommend metformin?
To the best of my knowledge, metformin is the only diabetic drug that has been proven to increase lifespan. So in America now, there's a lot of people in this field, some of the luminaries, who actually advocate for metformin as a longevity medication. And a lot of that is on the basis of animal studies. We know when you give metformin to mice, they tend to live longer. I certainly think if you're diabetic or have a degree of insulin resistance, then I recommend it for a lot of my patients. It seems to help people get into ketosis easily. It definitely helps with their weight loss. A proportion of them, maybe 15%, have troubles with a bit of nausea and a little bit of loose stool, but that tends to be very transient, and it often passes within 2 or 3 days. So for me, it's certainly, while I think that insulin is a terrible drug, and in actual fact, with the only review, insulin has never been compared to no insulin, and I was just looking for the data the other day, in a randomised controlled trial based on mortality. And the data we do have is not statistically significant, but the midpoint of that data, while not being statistically significant, suggests that all-cause mortality may increase by almost 3 times, about 2.8 times, when diabetics are commenced on metformin. Now, I didn't present that formally today because it lacks statistical significance, But I mean, it really makes sense, because if the problem is your body's not responding to insulin, you don't fix that problem by giving more insulin. So you get a short-term gain, and then in the long term that insulin will escalate. In the same way, you don't give an alcoholic who you're trying to help recover, you don't give them more alcohol. If you want to reduce their alcoholism, you give them less alcohol. So if we compare insulin to metformin, then metformin is worlds ahead. And I personally don't have a problem with it at all.
I'm into de-prescribing as a whole concept and coming off medication. Metformin was the start of my journey with my cancer. Someone brought it to my attention, a pharmacist. She said, look, there's all this stuff coming out of South America saying that people on metformin as a therapy with their end-stage cancer were living longer than those who weren't. And I thought, oh, this is interesting, because I had cancer. I've never taken metformin, but I thought, this is interesting. So here we've got a drug that lowers blood glucose or blood sugar, and therefore it's got a better outcome, and it's certainly the longevity studies are coming out about, why don't I just reduce sugar? And that began the start of my journey. But I've looked at the metformin stuff, and I agree, it's being advocated as a longevity drug. It's interesting, we actually don't know the mechanism that metformin really works. It's multifactorial. And yeah, so it's definitely associated with better outcomes, but would I put someone on it when I know that I can actually reduce their insulin-resistant state by reducing their carbohydrate load? Well, that's my first and foremost. But I don't think we know the answer to it, but there's a lot of...
Yeah, I agree. It definitely accelerates weight loss, from what I see clinically. But it's correct, I mean, it's got multifactorial mechanisms. When people ask me about it, I normally say, oh, it's a class of drug called a oneeyed, and that sounds quite complex, and then people think I'm smart enough, and I just hope that they won't ask me about how it works.
And a certain number of patients get nausea from it and don't tolerate it. The slow-release formulation is better, and they start off taking it at night time so they don't get the nausea overnight, and they get tolerant to that to some extent. But some people just really feel sick on it, so it's not a complete panacea either.
You've got to be careful not to use it as a substitute for a low-carb diet. I mean, there's the medical paradigm that we work under, is that we think medications, pharmaceuticals are the answers to everything, and so that's very attractive to doctors to give them a drug rather than a diet. I mean, metformin should be used if, in spite of a low-carb diet, you still don't have adequate control of your diabetes. That's the time you use metformin, not as the first line of treatment. It's sort of the second line of treatment.
Just another thing with metformin, I've done a fair bit of reading about how metformin depletes people of vitamin B12 and they can get nausea and numbness and tingling sensations, and it's often, it goes undiagnosed. So we were talking about vitamin supplementation. If you're healthy and you're not taking medications, you can get your nutrients from food, but medications like statins deplete you of coenzyme 10 and CoQA, whatever it's called, and metformin is widely known to deplete people of vitamin B12. So you might need supplementation or injections. So keep an eye on it.
So if I could just, we're going to finish up fairly soon. If I could just go through the panel with a sort of more simple question, actually. If you're giving people advice really about the psychological issue of giving up sugar, and I think all of us have talked to a lot of people about this over the years. And I know I'm putting you guys on the spot because we haven't prepped this question at all. Have you got like one or two points that you think are important to help people get over, let's say, the psychological as well as the physical addiction to the sugar?
Practice.
Practice?
I mean, psychologically, I mean, just even from a journalistic point of view, I read this information for about 3 years before I was ever confident enough to think that I could put together a program, the Heart of the Matter programs, because it just psychologically it had been drummed into my mind that, fat makes you fat and cholesterol causes heart disease, and I would read something that would be counter to that idea, and then I'd be all excited about it and read a bit more, and then after a while I'd be like, oh no, it's fringe, it's just too unbelievable. So it was really practice. I just kept reading about it, and eventually I got convinced of it. And I think the same thing can happen with smoking and sugar and other kinds of addictive habits. You might have to give it a few goes before you're successful at kicking the habit.
And Rod, I know you've just started up a program. Do you want to mention anything about the program with that?
Yeah, look, the whole psychological thing's interesting. I mean, knowing that sugar is addictive might be helpful for people to know that. And as I did mention earlier, I've started up, or Low Carb Down Under has started up an online course, and you're very welcome to flick an email to lowcarbdownunder@gmail.com, and we've got about 40 people enrolled at this point. It'll run for a couple of months. And it's got a number of components like short answer questions, it's got multiple choice questions, it's got some videos to watch and answer questions from it, it's got some interactive segments on it. Just something I've been keen on for quite a while, finally getting it off the ground, and invite you to partake. So thanks for giving me the opportunity to give that a little plug. Other conferences, or we'll come back to those later?
We'll come back to that at the end. Gary, questions about helping people get over sugar?
I've got 100 different ways of entering the topic with my patients. Doctor in Latin means to teach. Doesn't mean to medicate or to operate. It means to educate. And the very first thing I've got to try and find is the wedge into that person's head, because it's all psychology. And one very useful thing, as I say to my patients, well, not all of them, but from time to time, is that most of us are really interested in our financial retirement. And we understand the concept of saving money, dollar cost averaging, putting away money for that long-term future, and it compounds over time. How many of you are actually interested in your health retirement? Because everything you invest today and tomorrow, and you keep doing it over time, will only compound over time. And a lot of people get it. They go, oh, I planned my financial retirement, but I haven't planned my health retirement. It's a really good concept that gets the ball rolling. And when you come to a surgeon, we know that when you come to a surgeon, that's a very stressful time for patients, and it's a point of time when you can actually intervene in their life. The people most likely to succeed in convincing a patient to stop smoking is a surgeon. It's not a family member, it's not a general practitioner, it's not a physician, it's actually a surgeon. It's a crunch moment. And I mean, coming along and seeing Doron and myself and taking us seriously is a stressful moment for you.
I can't imagine anyone to take you seriously, to be honest. But the things that the things that I mention about to my patients is, first of all, it's going to be hard, and I think they have to realise that they can't just sort of switch off just like that. Secondly, that it's quite likely they'll feel like crap for 2 or 3 weeks, the infamous keto flu and so on. So you've got to warn them about that, because otherwise, they'll feel like rubbish after a week and give up. So again, you've got to, so I'll always sort of get them back in a week or two to sort of talk to them again and make sure that they're reassured and they're aware of it. And then the other thing is, I think the hardest thing that I found, and that I think a lot of people find, is just getting your head around the fact that fat is okay. I mean, we've been told for 40 years that fat is bad, and all of a sudden, a bunch of jerks up the front here saying, oh no, fat's okay, and you're saying, whoa, hang on a minute, whoa, and that's really hard. And I think that's what I struggle with, and I think that's what a lot of people struggle with. So, again, they're the sort of little pointers I would have, I guess, for someone giving up or moving on to a low carb type diet.
So you probably took away from Vicky's little talk before when she alleges that I told her to suck it up. I haven't always been the most empathic person when it comes to getting people to stop sugar. Now, I used to have 5 sugars in my coffee. I only say 5 because the truth is it was probably more, but I'd be embarrassed to say that. So I used to like my sugar, and it's definitely an addiction. So there's a couple of things, practical things that you can actually do to break the habit. So first of all, sleep is important. Sleep has 3 big effects. So it leads to dysregulation of 2 other hormones, leptin and ghrelin. Leptin helps you feel full, and sleep deprivation makes that lower. And ghrelin makes you feel hungry, and sleep deprivation makes that higher. And then When you're sleep deprived, you know your willpower is reduced. You know when you sort of lash out or you do something you probably shouldn't, it's when you're tired, when you don't quite have that degree of control. So if you're trying to resist sugar cravings, sleep deprivation is the single worst thing that you can do. You know, if you think about it, I often give people a sheet. If they fall off the diet, we say, why did you do it? One of the things that comes up frequently is sleep deprivation. The second point I'd like to make is that you need to distinguish between hunger and cravings. And the difference is, if you're hungry, you give into it. That's natural, that's allowed, you eat. If you're craving, then that's worth resisting, because with time those cravings will weaken. So for me personally, I call it the cheese test. Now, I used to get home, I used to go and sit on the couch, watch TV, and then I'd start to think, oh, I'm hungry. So I'd get up and go to the fridge. And I'd see the cream. And I don't feel like cream. I'd see the salami, not so much. I'd see the nuts, not really. I'd find where the wife had hidden the ice cream, bonza. Sit down and eat the tub. So the question is, was I hungry or was I craving? If I was hungry, cream and berries would have been a delicious snack. A bit of cheese would have been good. Some dried meat would have been fantastic. I wasn't hungry, I was craving. So I now, for a period of time when I was breaking that, I'd ask myself, when I'd say, I'm hungry, I'd say, would I eat cheese? And if I'd eat cheese, then I'd be, well, okay, it's not very carby, I must be hungry, I'd go and eat. And if I'd say, no, I don't even want cheese, doesn't matter, blue vein, camembert, the best, the Swiss Gouda, no, I don't want that, then I'd say, actually, you need to fight this. This is a craving, this isn't hunger.
So I think that's a great way to finish off. We're not quite done just yet. I'm just going to ask you to thank the panel, and then Rod's going to give us some messages. So thank you very much.